My name is Eddie Machtinger. I'm a physician, an associate professor at the University of California at San Francisco, and direct the Women's HIV program. Thank you so much for having me. My point today is that despite being engaged in care, women with HIV in the United States are faring surprisingly poorly, struggling with isolation, non-disclosure, depression, hopelessness, and addiction. We see this every day, but clinicians taking care of HIV-positive women are often hopeless because the interventions they have at hand are simply not successful. I've come to believe that unaddressed trauma underlies much of this suffering, and that identifying and treating this trauma holds the promise to significantly improve our patients' health and well-being. In this talk today, you'll see a number of pictures of my patients who have given me their permission and encouragement to use their images as a way of explaining that the face of HIV has changed dramatically. Since 1985, the proportion of cases in women has tripled. Now, between 25 and 30% of cases are women, and over 80% of those cases, like Cassandra, are in women of color. We live in one of the world's richest countries, yet the increasing numbers of HIV-positive women in this country are doing surprisingly poorly. This can be illustrated most typically by the HIV care cascade that you'll see on this slide. HIV-positive women are struggling at each step of this cascade. In the first step, 15% of HIV-positive women don't know their status. 30% of HIV-positive women have not been linked to care. Less than half are retained in care. Only a third are being prescribed HIV antiretroviral medications, and only 26%, a quarter, are thoroughly suppressed in their viral loads. But I think the amount of suffering experienced by HIV-positive women is not captured in the HIV care cascade. If you add health and well-being to the end of the cascade, which is really our goal, clinicians like me taking care of HIV-positive women will agree that the amount of suffering and despair and addiction and mental health issues lead women to have very, very low levels of health, safety, and well-being. The Women's HIV program where I work, suffice to say, is a Ryan White multidisciplinary program that provides an excellent array of medical and psychosocial services to our patients. Despite this array of services, our program, like many others treating HIV-positive women across the country, is faced with a daily vexing problem. Why are so many of our patients faring so poorly? And to answer this, we performed a cross-sectional study using 113 of our patients and a detailed data set from the 2-hour-long intake interviews that they do when they first arrive in our Prevention with Positives program. And we asked, which of these behavioral and demographic factors are most associated with virologic failure? And to us, the results were eye-opening. I apologize about this slide because it's so data-y, but the conclusion of this slide is that recent trauma, defined as being abused, threatened, or the victim of violence within the past 30 days, led to 4 times the rate of antiretroviral failure. 20% of our patients described recent trauma, and 70% of our patients described lifetime abuse. The next question that we asked ourselves was, were the rates of trauma that we were seeing in our patients similar to the rates of trauma across the United States affecting HIV-positive women in other places? And to understand that question, we performed a meta-analysis, which is an analysis that combines all of the data from all existing studies to determine the rates of trauma and post-traumatic stress disorder, PTSD, in US HIV-positive women. And again, the results were startling to me and to the rest of the clinicians taking care of patients. The rates of trauma and PTSD in HIV-positive women are strikingly high and much higher than the already high rates in the general population of women throughout the country. And let me call out 3 specific examples. The rates of intimate partner violence in an HIV-positive woman are 55%, which is twice the national rates. The rates of sexual abuse, lifetime sexual abuse in HIV-positive women are 60%, which is 5 times the rate in the national population of women. 60% of HIV-positive women have been sexually abused. And not surprisingly, the rates of PTSD, post-traumatic stress disorder, in HIV-positive women are 30%. This is the consequence of all of this trauma, 6 times the national rate. In our program, at the Women's HIV program, we have a case conference after each patient dies. And on this slide, I've listed the 8 deaths that have occurred in the past 2.5 years. As you'll notice, people in my program are not dying from normal things. They're dying from murder, suicide, overdose, and medication non-adherence. Let me just describe 2 of these women, all of whom we knew very, very well. Rose was a 58-year-old African-American woman who suffered from long-time crack addiction, who was murdered by her boyfriend and was found stuffed in a suitcase at our county dump. This was very, very, very upsetting for us, obviously. The last patient on this list is Pebbles. Pebbles was a 21-year-old African-American woman who we knew since her diagnosis when she was 15 years old. She suffered from a lifelong history of neglect, including the death of her mother from crack addiction. She died from non-adherence to her antiretroviral medications of a completely preventable opportunistic infection. And what I'd like to point out about all of these women is these women were all 8 of them, thoroughly engaged in care, had mental health screening, were engaged in treatment adherence programs, and were engaged in addiction counseling. And all of them had been screened for gender-based violence. Pebbles, for example, had been seen in our clinic 54 times in the 2 years prior to her death, including being seen by her case manager and our medication adherence program. Right before Pebbles died, we convinced her to get a neuropsych test that would help us explain possibly why she was having so much trouble with her medication adherence. And I'd like to read one paragraph from that report that explained to me why Pebbles had so much trouble believing us when we were telling her that taking her medicines would help her and lead her to a better life. The report says, I quote, "Pebbles is apt to find the world and all of its demands overwhelming. She may use physical pain to protect herself from feeling overwhelmed with the complexity of her emotions and the tasks she faces every day. Life has seemed beyond her control for a long time. She does not have the role models that are facing similar medical situations to gain encouragement and support from. Pebbles does not believe that the effort necessary to take all of her medications will really change her life situation. And so she didn't take them, and so she died." All of this data and these deaths have led our program to make a decision, which is to reframe our model of care to help women heal from past abuse and prevent further trauma. In medicine, it's incredibly helpful, though, when you're trying to reframe a program and trying to develop new treatments, to name the problem, because naming the problem can help you identify effective treatments, and if they don't exist, develop them yourselves. So I'd like to offer 2 definitions to you that I think are crucial. The first is for complex trauma. Complex trauma is defined as repeated or prolonged instances of interpersonal trauma, often occurring under circumstances where escape is not possible. Now, complex PTSD, complex post-traumatic stress disorder, is the result of complex trauma, and it's defined as having the core symptoms of PTSD, which is re-experiencing, avoiding, and hyperarousal, in conjunction with a range of disturbances in self-regulatory capacities. And by self-regulatory capacities, I mean in the capacity to contain and control your own emotions, behaviors, and relationships. The definition that is going to help us define and reframe our care model is complex PTSD. People are suffering from complex PTSD in far greater numbers than they're actually suffering from the results of current interpersonal violence. So we sought to reframe our model of care to be a trauma-informed primary care clinic for HIV-positive women. And despite the fact that there is increasingly a recognition of trauma on health outcomes, no one previously had operationalized a response to trauma in primary care. So we developed a model for one and are incrementally implementing that model. And our model is very, very basic, and it includes 3 core components. The first component is training your staff to be more trauma-informed so that our behavior as clinicians doesn't trigger women's trauma and instead helps them recover from trauma. The second element is to screen women for both recent trauma and past trauma and complex PTSD, and then refer them to interventions. And the third crucial ingredient is to have interventions to help women heal from complex PTSD somehow integrated into practice. I would encourage you not to be daunted by having to do all of these steps at once, because we're not able to do that either. But I would encourage you to at least pick one, such as having an outside agency come into your agency to teach you to become trauma-informed. Another example would be to talk more with your patients about their histories of trauma. And I'd like to share with you one promising intervention that we just completed at the Women's HIV program. I believe that HIV disclosure is crucial to help women heal from trauma and heal from the stigma associated with HIV. We partnered with a community activist and artist named Rodessa Jones to do a theatrical performance intervention where women would develop the skills and confidence to publicly disclose their HIV status and their histories of trauma. The women said that this was a transformative experience for them. To understand what they meant by that, we did a qualitative study of the impact of disclosing their HIV status and their histories of trauma and found 5 key impacts. One was sisterhood, catharsis, self-acceptance, safer and healthier relationships, and gaining a voice with which to educate the community. Notably, 4 of the 8 women who participated were able to avoid or leave abusive relationships, which is very important given the paucity of effective interventions to prevent violence amongst women. It's not that everybody has to do a theatrical performance disclosure intervention, because that might be impossible. But these core components of an intervention, to me, inform the goals of any intervention to help women heal from complex PTSD. This is a picture of the women who participated in the performance intervention who recently went to Washington, D.C. and were the featured performers in a large governmental conference. And to me, this is a very, very hopeful picture and experience, because none of these women were previously out about their HIV status or history of trauma. And this is them outside of the Capitol after lobbying Congress as out HIV-positive women and as women who have had histories of trauma. Trauma-informed care and addressing complex PTSD, to me, have great power and great promise. It's a much more effective and really, honestly, a much more satisfying way to address the root causes of many of the barriers to health and well-being seen amongst our patients. It also has great potential power to not only affect the health and well-being of the 350,000 HIV-positive women throughout this country, but the far greater number of women in this country and abroad who have been victims of violence. Thank you so much for coming and listening today.